Good afternoon, everybody. Welcome to Grand Rounds. Today I have the pleasure of introducing co-presenters. Catherine Kingsbury received her BS in Speech Pathology and Audiology from Miami University, and she's currently at the University of Iowa, progressing towards her master's and Doctor of Audiology degrees. And our other presenter is Elizabeth Stangl. She received her undergraduate degree at the University of Oklahoma in Communication Sciences and Disorders, and then received her MA and Doctor of Audiology degrees at the University of Iowa. They both currently are affiliated with the Wendell Johnson, or in the Department of Communication Sciences and Disorders at the Wendell Johnson Speech and Hearing Disorders at the University of Iowa. They very graciously accepted our invitation to present at Grand Rounds today. And please join me in welcoming Elizabeth Stangl and Catherine Kingsbury.
Thank you so much for the wonderful introduction. So kind of before we get started, we have our little pictures of our Wendell Johnson Speech and Hearing Clinic, which will be no more in a few months. We're moving to a new building, which is really exciting at the University of Iowa. So we have a lovely new built speech and hearing building coming soon. So out with the old, in with the new. And I'll let Elizabeth kind of finish introducing herself and her role here at the university before we jump into our slides. Elizabeth, you're muted.
When I switched to my PowerPoint presentation, my Teams window went away. Okay. Can you hear me now?
Yep, we're good.
All right. So I am a research audiologist and a clinical audiologist here at the Wendell Johnson Speech and Hearing Clinic. I do research in the hearing aid and aging research lab. So I've done a lot of hearing aid research over the years. And then I'm also a clinical audiologist in our teaching clinic, as well as being one of the co-directors for Healthy Hearing Division of Special Olympics Iowa, where we provide free hearing screenings for our Special Olympics athletes from Iowa.
So to frame our presentation today, we see that hearing loss is very common within the US and around the world. It's the third most common condition within the US, so it's affecting a very large population of people. However, we also see that hearing loss is often underdiagnosed compared to other major conditions, as well as undertreated. We see that hearing loss isn't often approached the same way as maybe a yearly physical or other appointments. Hearing is often maybe not as prioritized as much, but we do see that a lot of people are affected by hearing loss. And then even if people do get their hearing tested or screened, there's a real lack of action after those steps and with that information with adopting treatment and amplification for it. So I think we often see between people getting diagnosed with hearing loss, having that confirmed, and possibly adopting hearing aid or other amplification can take anywhere from 8 to 9 years if they choose to pursue that. So we really see this not only big delay, but also a much smaller proportion of who would benefit from amplification via hearing aids, cochlear implants, and other methods are actually choosing to pursue that. And we also know that hearing loss can cause a lot of communication difficulties, not just one-on-one, but we also see these can cascade into other areas of our lives, affecting our participation in society, as well as our mental well-being when we're maybe not able to engage as we used to really connect to those people around us. So I think often we analyze sometimes the surface effects of hearing loss, but it can really affect people in many ways and in many aspects on a deeper level. So we know that y'all physicians are aware. Studies have shown that physicians are aware of patient susceptibility of hearing loss via aging, noise exposure, and other disease processes. You guys are aware of these negative impacts that hearing loss can have on individuals' daily lives. But we see somewhat of a disconnect between knowing about hearing loss, all these negative effects it has, and then possibly about the benefits of hearing aids, cochlear implants, and other amplification solutions we can provide for patients. So hopefully after today, we're able to provide a bit of a gap, fill that kind of area of, we understand this is definitely a big issue. How can we as providers provide the best information and best direction for our patients so they can get really the care and support that they need? And we also see that there are a number of barriers to referral that we've kind of chatted about already, possibly negative perceptions about how patients prioritize hearing. I think within the spectrum of what people are dealing with, we do acknowledge that hearing is sometimes only a small part of what patients are dealing with and handling in their daily life and with their medical needs. So often, sometimes that can get less prioritized, especially within a medical setting and even in that patient's own life. And then also, there is a big gap with our insurance coverage for hearing healthcare services. So it's also a lot of uncertainty about patients' ability to afford devices and amplification and or adapt and use them. I think there is definitely issues with how expensive devices are, and we've seen some of that area filled with over-the-counter hearing aids, but it's definitely still an issue that affects a lot of people's access to hearing healthcare, as well as people's adaptation to those devices. So we'll kind of start with a little primer to set up what hearing loss can maybe be like in a medical, some medical environments. I think often we maybe just solely think about, oh, maybe they're struggling to understand directions within this appointment, but hearing loss can really cascade down to for when patients enter the door. So this is just a little video from Cleveland Clinic, just providing a few kind of empathetic situations so we can maybe better understand what someone with hearing loss might be struggling with. So it's just a few prompts to kind of walk us through that experience.
Hearing loss is invisible.
Perfect. So now we're going to jump back into our slides, but I think sometimes that just helps as a helpful primer or introduction to think about, okay, maybe I'm expecting patient difficulties in my appointment with them, but how can that affect their whole medical experience at an appointment or throughout their encounter in a hospital? So I think kind of understanding that and thinking through that, we know that about 50% of information the patient get in an appointment is forgotten right away. And then of that 50% further is remembered incorrectly. So then if we think about the compounding effect of hearing loss on those different interactions, we can maybe have some empathy and really think about how we can be adapting our care we're providing to hopefully be a little more inclusive and accessible to those patients. So most of you probably had a very thorough review of anatomy and physiology of our ear and hearing system, but we're just going to play this video as a short review just so we're all on the same page and just as a good little refresher.
Have you ever wondered how sounds make their way from the source all the way to your brain? Take a trumpet, for instance. When it's played, it makes sound waves in the air. The outer ear catches the waves, which then travel through a narrow passageway called the ear canal. The sound waves reach the eardrum, which is a membrane roughly half the size of a dime. They make the eardrum vibrate, which in turn vibrates 3 tiny bones called the malleus, incus, and stapes. These bones amplify or increase the sound vibrations and send them to the cochlea. The cochlea is shaped like a snail and is the size of a garden pea. It is filled with fluid, and the sound vibrations make this fluid ripple, which creates waves. Hair-like structures called stereocilia sit on top of hair cells and are grouped together as hair cell bundles inside the cochlea. The hair cells inside the cochlea ride these waves, and the hair bundles are moved. The hair bundle on top of the hair cell turns these movements into electrical signals. As the hair bundles are moved, ions rush into the top of the hair cells, causing the release of chemicals at the bottom of the hair cells. The chemicals bind to the auditory nerve cells and create an electrical signal, which travels along the auditory nerve to the brain. Different hair cells respond to different frequencies of sound. The hair cells at the base of the cochlea detect higher-pitched sounds, such as a piccolo or flute. The hair cells toward the top of the spiral detect progressively lower-pitched sounds, such as a trumpet or trombone. At the very top or apex of the spiral, the hair cells detect the lowest-pitched sounds, such as a tuba. The auditory nerve carries the electrical signal to the brain, which interprets the messages as sounds that we recognize and understand.
Okay, so now that we're all kind of on the same page, we have that overview and kind of reminder of our 3 divisions. We're going to shift into talking about the types of hearing loss with that anatomy and physiology in mind. So we first have conductive hearing loss. Our second type is sensory neural hearing loss, and then finally mixed hearing loss. So we're going to dive into a bit more about these different types of hearing loss and the implications they have. So with conductive hearing loss, that's typically pathologies affecting that outer or middle ear. So of our 3 divisions, outer, middle, and inner ear, this would be affecting one of those first 2. So how sound is transferring from the air all the way through our system. So this is typically can be medically treated to restore some or all of hearing. So a lot of this is where physicians really come into play. And so from this pathology, sound is not being conducted normally from the outer world all the way up to our inner ear, to our cochlea that can send those signals up to our brain. So with this type of hearing loss, typically our inner ear or that cochlea and our auditory nerve is functioning just fine. However, we have this difference in what our sensory system is perceiving via if we present bone conduction or kind of skip that outer and middle ear versus what's happening when we present sound through the whole system. So it has to pass through that outer and middle ear. This can typically be caused by the most common ear infections, either outer or middle ear infections. Sometimes excessive earwax where it's occluding that canal and really blocking off those sounds. Some malformations of the middle ear bones, either disarticulations, bony growths, can really impede that transmission of sound to our sensory system, as well as other genetic factors and genetic disorders. Then when we look at sensory neural hearing loss, this is typically permanent. A lot of what we're dealing with in our hearing aid clinic are patients with sensory neural hearing loss. So when we say sensory neural, we're dealing with issues in our inner ear, and so either sensory system cochlea or that auditory nerve with the presence of a normal outer or middle ear. So this is often caused by aging or presbycusis, excessive loud sound exposure. So noise-induced hearing loss is the most preventable form of hearing loss that we see. Some medications can be ototoxic and damage those hair cells or our nerve within our hearing system. Some viruses, autoimmune diseases, tumors that grow in our auditory nerve or in other places that ultimately either grow over the nerve or just are so space occupying that they affect these regions, as well as other genetic mutations and genetic disorders. So kind of the big buzzword, I guess, when we're talking about sensory neural hearing loss and our hearing health are hair cells. So we see within our cochlea running along the whole length, we have 3 rows of outer hair cells shown in this picture in those little V shapes, and then 1 row of inner hair cells. So in someone with healthy hearing, newborn baby, young child that doesn't have a lot of loud sound exposure or aging, we would see something like this. Hopefully we have well intact hair cells that are going to be able to respond to those vibrations. And our outer hair cells are serving as those protectors and also amplifying our response, our frequency specificity, and those inner hair cells really working to send those signals to the brain. So on the next slide, we have kind of our damaged hair cells. So in a lot of our patients with more severe degrees of hearing loss, their cochlea might look somewhat like this, where we barely have any of those outer hair cells left, barely can see those 3 rows, and our inner hair cells are starting to be damaged, bent. And when we have hair cells in this condition, they're not going to be able to transduce those signals to the brain as effectively. So then our final type of hearing loss, mixed hearing loss, it's a combination of the both of those. So possibly in a patient that already has an established sensory neural hearing loss, so issues with that inner ear, and then they have a conductive pathology on top of that. So it might be transient, such as they come in, they have a middle ear infection on top of an already known sensory neural hearing loss, or something more permanent with a conductive nature. So then apart from our types of hearing loss, we also have our degrees of hearing loss when we're looking at our hearing tests. So we first have mild hearing loss. So anything we say above 20 or 25 dBHL, we consider normal hearing. So people in that range, we would consider normal. So mild hearing loss is typically from 25 to 40 dBA. And if we think about the impacts for this person, it's likely going to be affecting their ability to maybe hear whispers, focus on conversations and background noise. So maybe they're having to put a lot more effort and experience some of that listening fatigue in those environments with more background noise, as well as possibly discerning certain consonant sounds. Our consonant sounds are a lot more high frequency information, and they are typically less intense than vowel sounds. So people might be struggling with speech clarity at this point. Then if we look at moderate hearing loss, that's anywhere from 40 to 70 dBHL of hearing loss. So we see at this point it's going to impact likely ability to follow conversations even in quiet, especially as we're getting closer towards that more moderately severe range, that higher end of moderate. And at this point, it might be difficult to understand speech from women or children with those higher pitched, sometimes softer voices. Our patients come in especially noting those difficulties, especially when we're seeing hearing loss in those higher pitches and higher frequencies. And then it might even be hearing ringing of doorbells, telephone, their microwave, some of those environmental sounds too. For severe hearing loss, now we're getting progressively worse. We're at 70 to 90 dB. And at this point, this is going to really impact their ability to hear most sound without a hearing aid, even in quiet. So these people are really going to be needing amplification in order to engage in those verbal conversations, and then especially difficulties on the telephone. And then finally, anything above 90, we consider profound hearing loss. At this point, it can be difficult to experience any benefit from a hearing aid. Now we might be switching to a cochlear implant or other interventions simply because of the severity. Hearing very loud sounds might be impaired or very much lessened, such as even sirens or airplanes. And then patients without amplification might be using sign language, lip reading, written assistance to communicate at this point with this degree of hearing loss. So what we have now is our audiogram of familiar sounds. So this is something that we use a lot of times with patients after we test their hearing to help them better contextualize how their hearing loss is affecting them. I think too many times we give our patients our audiograms, we have our pitches running low to high, and then intensity and loudness running from soft to loud. And they're like, okay, I know this, but how is this affecting me? How is this translating to my everyday life? So we plot a number of common sounds, kind of where they fall pitch-wise, as well as intensity or loudness-wise. And then kind of what we really like to focus on with our patients that come in specifically for hearing aids and difficulties with conversation is what we call our speech banana. So that beige region, we also see a number of letter sounds. Those are plotted on average, the intensity as well as the pitch of those different consonant and vowel sounds. And when patients see this, this can often really help them contextualize some of the difficulties they're having. They might be like, I'm not hearing S's anymore, or I'm hearing, but I'm not understanding speech. So helping them understand, and even as providers understand, how might my patient's hearing loss be affecting them, not only with different environmental sounds, but also specifically speech, can be really helpful. We see those vowels are more intense, typically louder in volume, where a lot of those consonants or shaping sounds for our patient's ability to understand speech can really be affected a lot sooner. So now we have a little hearing loss simulator. This isn't comprehensive or exact for every patient's hearing loss, but we use this a lot of times to help build empathy with family members, friends, and it's also sometimes a good tool to share with staff. So Elizabeth, I'm going to have you go to meeting, and then we're first going to play what it might sound like with normal hearing.
Give him a call. Ask him if he would get in there February 15th.
I'll do that.
Will do.
Oh,
that sounds good. That'll give him enough time.
Yeah, which is good because that's right on track with a project that I'm doing to make sure that all the tenants are knowing about what the parking.
Yeah.
Perfect. And then we're going to simulate a moderate hearing loss. This obviously isn't exact. It really depends on the configuration of a person's loss. So maybe what pitches they're struggling with the most, but this can kind of help us understand maybe how much more difficult it would be with a moderate hearing loss.
Because we got a lot of restriping to do. Yep. We've got some repairs to do from the road.
Give him a call. Ask him if he would get in there February 15th.
I'll do that. Will do.
Oh, that sounds good. That'll give him enough time.
Yeah, which is good because that's right on track with a project that I'm doing to make sure that all the tenants are knowing about what the parking.
Yeah.
So I think from this, while it's not exact as we say, for a lot of our patients, it can help their family members and friends really contextualize some of the struggles they might be having. We see not only did just the volume get softer, but we lost a lot of those shaping consonant sounds, and we see some of those letters get blurred out, hopefully to kind of help us possibly understand what information we're missing. So I think for us, we had that sample before with normal hearing where we're getting all of the access to most of the information. So we even have a bit of a primer of what we should be expecting, but especially in those more difficult situations with multiple talkers, possibly a medical environment where you're having questions from different family members, friends, providers, it can be really hard to follow. So this can be a good tool possibly to share with other staff members, families, friends, and even just for us thinking about how are our patients really being affected by their hearing loss.
Okay, so now we're going to switch over to more of the kind of the research in this area. So some quick statistics: about 60.7 million Americans over the age of 12 have hearing loss, and that number is expected to almost double by 2060. So that's a lot. And about 15% of adults over the age of 20 have hearing loss as well. And you can see from the bottom percentages that the hearing loss rates increase as we age, which you can tell that just probably by people that you know in the world and have experience with in clinic as well. So the effects of hearing loss can be quite negative. It can affect quality of life, being that people are not as able to understand in social situations. So they tend to retreat because they don't like asking people to repeat themselves, or it makes them feel dumb that they don't understand what someone's saying, or they think that it makes other people think that they aren't as intelligent because they aren't getting what people say. It can also impact independence for the same reason. They can't understand what people are telling them if they are running errands or seeing their physician. They have to bring someone along with them as another set of ears. It can really strain those interpersonal relationships because if they're less independent, that puts more stress on their partners. And then because they don't have as healthy of relationships, that can really affect their mental health. It can create anxiety, depression, and just really a sense of not belonging because they can't interact with people. It can also create tinnitus, or that ringing or buzzing in your ears. And a lot of people have been told, even by their primary care physicians, that we can't do anything about tinnitus. But actually, Katie's gonna talk to us about some of the therapies that we have available and some counseling that we have available here at Iowa too. So all is not lost. There are strategies for individuals who do suffer from tinnitus to try to make that less impactful on their daily lives. Research has shown that even with a mild hearing loss, our brains begin to reorganize our sensory perception. So when we first started implanting patients with cochlear implants, we started out with individuals who were profoundly deafened, and some of them had never been able to hear. And with those patients, at first, sometimes that signal was more tactile, like they felt the sound rather than hearing it. So at that point, their brains had reorganized that auditory perception area in their brain to be more of a tactile sensory. But with time, they began hearing signals rather than feeling them. Hearing loss can also affect your balance. There are significantly more falls for individuals with untreated hearing loss. Katie also mentioned that listening fatigue. So if you have to pay attention and really focus on what people are saying to follow a conversation, that can wear you out by the end of the day. For children or college students, if you can't hear what your lecturer is telling you or your TA is telling you, then that can impact your educational development. And even children with unilateral hearing losses, so just hearing loss in one ear, they are much more likely to repeat a grade than their typically hearing peers. And kind of that interactions with services, so medical providers and things like that. When you can't hear it, you're much less likely to go and seek those services. And then you can also have employment or career deficits as well. If you can't hear as well, you may not get that promotion, or you may not even try to apply for a promotion or a different career because you think, oh, they'll just give it to somebody else who can hear better. And there's kind of a divide between the social interaction between people who live in more rural and urban settings. And since Iowa is pretty rural in some senses, they are much more likely to suffer from the depression, loneliness, anxiety impacts of hearing loss. Okay. And then there are also healthcare costs related to untreated hearing loss. So compared to normally hearing peers over a span of 10 years, individuals with untreated hearing loss have higher medical costs. They are more likely to have an inpatient stay in the hospital. They are more likely to have a longer stay by usually about 2 days. They're more likely to be readmitted within that 30 days. They typically have more outpatient health-related visits as well, and they're at increased risk for emergency room visits. So this information was gathered by looking at insurance claims from, I think, 2005 to 2014, and we know that things have probably even increased in the last 10 years, so that number is probably a lot larger now. So what should the physician's role be in managing that age-related hearing loss? So there was a study done where they asked a group of general practitioners and adults with hearing loss. In my opinion, the role and responsibility of general practitioners in managing age-related hearing loss is, so it was an open-ended prompt, and then they proceeded to ask the participants to brainstorm what that role should be. And this was all done online, but everyone could see everybody else's answers. They weren't able to comment on them, but they could add to and build on the statements of the participants who had previously participated. And overall, they came up with about 6 different concepts. So the first one was to describe the process of testing hearing and determining the cause and discussing the implications of that diagnosis. And while that might be out of the scope of practice for some general practitioners, that's where Katie and I can come in and help with that. So just referring to a hearing healthcare professional will really help in that area. Another area that they found was to ask, assess, and act. They want their practitioners to look for hearing loss symptoms and understand how those hearing losses can affect daily activities. They want you to normalize that hearing or getting help for hearing loss is okay. It doesn't mean that you're old or less than, and they want their physicians to promote action. So to not let them just say, oh, it's normal for someone my age, but to actually help them find that rehabilitation. And they just want to have the general practitioner actively make hearing loss part of the conversation. They might not bring it up themselves, but they like their physicians to ask how they're hearing. Another area is to know, refer, and coordinate. So this kind of goes with that first one, I think. So referring patients for services, and they especially liked a local specialist for those hearing related services. And I'm not as familiar with the professionals in Ames. My husband is from Ames, and I've been around there a little bit, but I don't know any audiologists there. But it wouldn't hurt to develop some referral relationships for your patients who need it. Informing, advising, and partnering was another area. They want you to care about them and join them on their rehabilitation, asking, is this working? Do we need to find a different professional? And just knowing that they are being successful with that journey. They want their GPs to educate, strategize, and encourage. So they want you to know about different intervention options. So hearing aids, cochlear implants, tinnitus management, that type of thing. And also employing communication strategies. And Katie, again, will talk about those at the end as well. They are a little common sense once you think about it, but if you haven't, they might be new to you. And finally, they want their GPs to reassure, support, and empower. So they want sympathy toward their concerns. They want you to understand that impact of hearing loss on their life and to provide that emotional support when going through that process. All right, so how can we implement those strategies? We can communicate effectively, and we'll give you some tips on how to do that later. Just refer for hearing tests when your patients mention symptoms. Medical practitioners are a very trusted source of information. And if you downplay the effect of hearing loss on their life, then they'll probably think, oh, it's no big deal. But if you listen to them and refer, then they're more likely to take action. And some research has shown that medical practitioners are unlikely to spontaneously discuss hearing impairment. I think because of that stigma with hearing loss being for more prevalent in older adults, that it becomes more of a taboo subject. You can complete in-office screenings, and I'll talk about those on the next slide. Or there are lots of online or smartphone tablet-based hearing tests that can give you a pretty good idea of whether you would need to be seen by an audiologist for further services. So in-office screenings, although they do take time, which is probably the biggest barrier to doing these, they can be done by the medical assistant, nurse, or a physician. It can be easy as a direct inquiry of, do you feel you have a hearing loss? There are screening questionnaires. So I have one pictured here. That's the most common one, is the hearing handicap inventory for elderly. There are digits and noise tests and these can be implemented on a telephone. A lot of the online tests are digits and noise, and most of the app-based ones are this way as well, where there is a computer-generated voice that lists 3 digits, and then the participant has to type in the noises or the numbers that they hear into the phone or on the app. The whisper test is one that a lot of physicians do, along with that finger rub test. There are also handheld screening devices that that can test or screen hearing in office. But those are a little more expensive than the free ones that I just described. So barriers to completing in-office screenings, we know that we never have enough time. Workflow is another thing. Who's going to do it? Where does it fit in? Space. You need a quiet space to do these screenings. Presence of earwax. We have to refer a lot of times to have ears cleaned before we can do a thorough hearing evaluation. So that can be an issue of, is it an actual hearing impairment, or is it just a wax buildup? And then reimbursement. The reimbursement for hearing tests are not great, and there are not reimbursements for screenings. So there are several studies that have looked kind of at the sensitivity and specificity of the screening test that I described. And the one that is the most sensitive is that whisper test. So to do that, you would stand an arm's length behind your seated patient and whisper a combination of different numbers and letters, and then ask the patient to repeat them. And you have to be behind them so they can't read your lips. You have to exhale first before you say the numbers and letters, just so you can try to keep your voice at a steady level. And I think it's harder to test the different ears. You're supposed to have your patient plug one of their ears. But that can be only so successful. There are some limitations to it as well. It takes time to master because you have to know the right voice level. You might whisper too quietly if you haven't done it before. It also assumes that your hearing is normal so that you can hear your patient's responses as well. It's not standardized, so you can pick any letters or numbers that you want to. And because of all of those things, it can be hard to reproduce reliable results. And so that just a direct inquiry has been found to be or have a rating of about 0.7 on specificity and sensitivity, where the whisper test is at about 0.75. So it's actually very similar. So just asking the person, do you feel you have a hearing loss, can give you a really good idea of whether they need to be referred for further audiological services. So what happens when you refer your patients? So typically they'll come in for a hearing evaluation and communication needs assessment. And during that time, we will test the different frequencies. We'll have them repeat speech, both in quiet and background noise, and find different or comfortable levels of speech for them, as well as uncomfortable listening levels. If we find that they do have hearing losses, we will then schedule them for either a hearing aid evaluation if they're in the range of kind of mild to moderately severe hearing loss. If they have more severe to profound hearing loss, then we would schedule them for a cochlear implant evaluation. Individuals with severe to profound hearing loss can also use hearing aids. They just aren't as successful because typically by the time we have that more severe to profound hearing loss, a lot of our little hair cells are gone. And even if we make sound louder, it's not going to make a whole lot of sense to our auditory system. It'll be distorted or just kind of painfully loud. We usually don't have issues hearing loud sounds. Those little hair cells are there to help us hear soft and medium level sounds. So by the time we've lost all those hair cells, even if we amplify it doesn't make any sense to our brain. So it's better to have the sound translated into an electrical signal, which is what our hair cells and our cochlea are supposed to do. So if you have that done by that cochlear implant, it bypasses that damaged organ, and then we can send that electrical signal to the brain. If we find that there's a conductive or a mixed hearing loss, we refer to an ENT to see if we can have that conductive component resolved. If we can't, there are other specific hearing aids that work just with that conductive hearing losses. And then also if someone's primary complaint or an additional complaint is tinnitus, there are several options on how to treat that as well. So amplification, you can use prescription hearing aids. Anyone can be fit with a prescription hearing aid as long as their hearing is in that mild to severe range. And we actually even have some patients that have essentially normal hearing so they don't have a measurable hearing loss, but they have kind of a perceptual hearing loss, and they find that the use of hearing aids helps them focus. It could be a lot of times they're teachers who want to hear their kids in the classroom, and it could also be someone with what we call a central auditory processing disorder, where there's no real measurable hearing loss, but there is a lot of impact of being unable to understand others in their daily lives. There are over-the-counter hearing aids. Those have been available for the last 2 years, and they're supposed to address the cost and accessibility barriers to hearing aids, because audiologists are often urban, and the hearing devices they're pretty expensive, little medical computers that sit behind your ears, which a lot of people cannot afford. They're also mostly not covered by insurance, so that the creation of that over-the-counter hearing aid makes them less expensive because there's no service provider to increase the cost. But at the same time, there's no service provider, so it is all on the patient to correctly diagnose their hearing loss and pick the right device and teach themselves how to use it. So there's a trade-off there as well. And then we also have bone conduction hearing aids, and those can be just for that conductive hearing loss or for single-sided deafness as well. Okay, and I kind of got ahead of myself on these. So we have talked about most of these. With prescription hearing aids, there is a 30-day adjustment period for any hearing aid that is purchased. So a patient can return it for any reason and receive their money back. And that's not always the case with the over-the-counter hearing aids. And then those over-the-counter hearing aids are also only for adults without any what we call red flags. So that's usually things that we would automatically refer to a medical professional for. So asymmetrical hearing loss, which how would they know, because they haven't had their hearing tested. Could be ringing in only one ear, It could be that conductive component, which again, how would they know because they haven't had their hearing tested? Vertigo or dizziness, but they're there to create a more accessible product. Because the vast majority of individuals with hearing loss just have mild to moderate hearing loss. There are lots of resources on the internet for over-the-counter hearing aids. The American Association of, I'm blanking on the American Speech Language Hearing Association, has resources. The American Audiology Association also has them, as well as the NIH and the FDA. And then there are several websites that provide reviews and information on all sorts of hearing aids, including over-the-counter hearing aids, such as hearingtracker.com and soundly.com. Okay. For those bone conduction hearing aids you see in this picture, it's of a child wearing a headband, and then that bone conduction hearing aid just sits behind their ear and sends the sound vibrations through the bones rather than through the whole auditory system. Because if we send the vibrations through the bones of the skull, they go to the cochlea instantaneously. They bypass the outer and middle ear where that pathology is. You can wear them with the headband as shown there, or you can have an abutment implanted in or embedded in the skull, and that actually gives a better contact with that mastoid bone, so your ear can receive those signals a little bit better. Okay, I think I've maybe talked into Katie's part again.
Okay, so kind of our next option we have is for cochlear implants. This is when we have patients, the biggest indicator for a lot of our patients outside of that range of hearing, if it's very severe to profound, is also a lot of our patients say, I'm no longer receiving benefit from a hearing aid, or I'm not receiving benefit from a hearing aid, especially with our older patients. With our younger patients, some of those children, they might be failing those newborn hearing screenings, receiving ABR diagnoses that they have severe to profound hearing loss. So cochlear implant, it's a surgical device, and it works by bypassing those damaged hair cells and stimulating our auditory nerve directly. So with a hearing aid, we're putting it in our ear canal. It's going to have to travel through that outer, middle, and inner ear, but our cochlear implant is bypassing that by sending electrical signals directly kind of close to that auditory nerve. And CIs have come a long way since they've been introduced in the 1980s, being effective and a successful tool for providing audibility for people with those more significant hearing losses. And this is just a little picture. So we have usually an external and internal portion. We can skip the video. We kind of talk through most of what this video will discuss, but it's a good resource from one of the main manufacturers. And it kind of shows those external and internal components of cochlear implants. So the internal portion that is placed and surgically implanted by a medical physician, and then that external portion that's typically programmed by an audiologist.
And then many studies have shown that amplification and cochlear implants do help. And I kind of feel like this slide is out of order. Let me put that. Yes, it is out of order. So Katie, go ahead and talk about tinnitus.
So we mentioned earlier that a lot of our patients with hearing loss also experience tinnitus. You don't have to have hearing loss to experience tinnitus, but a large proportion of people that do have hearing loss also have tinnitus co-occurring. So different studies report that anywhere between 8 to 25% of the U.S. population experiences tinnitus or tinnitus. Either way is correct. When we're talking to patients, they might know I have a ringing in my ears, but nothing else is present externally. So kind of thinking about how physicians might be talking to patients about tinnitus. So there is currently no surgery or drug known to reliably eliminate or take away tinnitus. But I think a lot of our patients hearing that, they've heard that maybe from other providers, they lose a lot of hope. But there are a lot of things we can do to hopefully manage our patients' tinnitus through a number of different options. So we sometimes like to talk about tinnitus management rather than tinnitus treatment, because for most of our patients, tinnitus, we can't take it away, but we can maybe decrease its prominence, help them cope with it in their daily life, and work to make their quality of life a lot better. So we'll have on our next slide some information for support groups here in Iowa. These can be very helpful for different patients. Right now, there's online tinnitus support sessions being offered by Dr. Julie Jian here at the University of Iowa. We sent her handout as well. They're completely free. So it's just a good option for patients that are maybe looking for more information or community about it. And then if we want to go back to our slides about other management options, there's also a number of bimodal stimulation devices that use sound therapy as well as stimulation on other parts, whether the tongue, the neck, other areas of the body, that have been shown to help possibly decrease the prominence of people's tinnitus, either modulating the pitch or intensity, or sometimes just simply helping that person cope with it better. For a lot of our patients report wearing hearing aids can help. When we have patients come in with complaints of tinnitus and they get fit with a hearing aid, a large majority of them note that their tinnitus is less noticeable with those hearing aids on, simply because they're getting increased access to other environmental sounds, other voices that are almost acting as a natural masker to cover up possibly that tinnitus they're hearing otherwise. So I'll hand it back to Elizabeth to kind of talk about the benefits of hearing aid use.
Yeah, so both hearing aids and cochlear implants really, by increasing our patients' access to sound, help them to interact with others in their life, and that kind of helps to overcome those negative effects of hearing loss. And with this table here on the right, it shows how many people are satisfied with how they hear with or all of them have hearing loss, but none of them own hearing aids. And when you look at how much more satisfied people who own hearing aids are in those different listening situations, here on the left, it's quite a dramatic increase. So they can be very beneficial in a lot of different situations and can greatly improve their quality of life. So this table or graph shows that hearing aid owners are more likely to regularly exercise, socialize, feel engaged in life, and feel less forgetful than those without hearing aids. Okay, and now Katie will go through some of our communication tips here.
So to kind of wrap our session up for today, as we said, a number of these might feel like, oh, kind of common sense, but a lot of our patients appreciate hearing about these and even help modify how we're interacting with our patients. So first, making sure we're getting our listeners' attention, speaking slowly and clearly, but not exaggerating our words, which can distort the sound, speaking up, but not shouting, and also rephrasing what we're talking about. If we simply keep repeating the same thing over and over, the person still might be struggling with those same speech sounds in certain words. So how can we communicate that in different ways? And then also using simple and direct language. If we don't need to use complex language, it can be helpful to really avoid it in those situations. So that living room language we try to use in a lot of situations anyway. And then, especially with the rise in PPE, if we can, making our communication visible. So if we're not wearing a mask, making sure we're not putting a clipboard or our hands in front of our face, wearing a clear mask if possible. We know this isn't always the case, but if you have someone who possibly has interpreter services or you know that they might be struggling, this can be good. And then using our body language to help convey some of those messages as well as optimizing that environment through positioning and good lighting. And I kind of touched on this already. So with our environment, maybe minimizing that background noise. So lobbies can be really busy, loud, and crowded. So maybe if we're having a very important discussion, making sure that's happening in a quieter exam space, or providing those written instructions with appointment times, important directions, so that person can repeat them back. Having that written information, taking pauses to confirm. And then a big thing we like to focus on is the teach back method. So rather than just asking your patient, did you understand me? A lot of times patients, and especially patients with hearing loss, will just say yes, because they don't want to confront it, they don't want to worry about it. But having her say, okay, what did I just say to you? Or can you effectively show me what we just talked about? Can be helpful to confirm your patients understand you correctly. And then using devices. So if a patient has a hearing aid or cochlear implant, making sure it's on when possible. We know it's not always possible in all situations. Understanding that someone with hearing loss might use a remote microphone. So maybe asking about that. And if they do wear one, making sure we're clipping it onto our shirt collar, avoiding their name tags or necklaces rustling on it, and using that properly. And then also utilizing a lot of free text-to-speech software. There's a number of great ones, such as AVA, or even ones within the medical community that can help our patients understand our message in written form. So knowing that hearing loss takes a lot of energy, we talked about listening fatigue. So maybe understanding that when we're providing information, giving some pauses, allowing to make sure we're not understanding when someone isn't feeling well, they're there to see you for something else, that listening fatigue might be even worse because they're already physically fatigued from an illness. Taking turns when speaking in a group, and maybe seeking out that person if you can tell they're struggling to understand where sound's coming from, or localize your voice in an environment. And then we kind of touched on tinnitus. If someone has tinnitus, it might also be competing for their attention and adding to that listening and daily fatigue as well.
All right, so we have talked over our time, actually. So just to wrap up, physicians are a trusted source of medical advice. So, please use your role to help our older adults, or any adults, reach out for hearing services. You can play an important role in that early detection of hearing loss, and the sooner we participate in hearing rehabilitation, the better we can preserve those brain pathways and preserve speech understanding abilities. Successful in-office hearing screenings are as simple as just asking if they feel they have a hearing loss, and hearing aids and cochlear implants can significantly increase quality of life. And with that, do you have any questions?
I'm not seeing any questions in the auditorium. If there are any, please speak up. Nope, doesn't look like we have questions in the auditorium.
I'm not seeing any questions in the chat either. So I just want to thank you all so much for your time and energy listening for us today. I think this is really important collaboration and understanding both how we can support you as audiologists and also understanding your role as physicians within a patient's hearing healthcare journey. So hopefully this was helpful today, and we really appreciate your time.
Yes, thank you.
Thank you for presenting.